so much, Katie, for that lovely introduction. Um, yeah, as Katie said, there is a lot to cover in reimbursement, and essentially the kind of the opening slide pretty much says it all. You're looking to find out, will you actually get paid for your device? Now, if you're working in a startup and you're launching your device, people tend to start off very heavy on QARA and quality assurance and regulatory affairs, determining their regulatory approval pathway, and then also working very hard on the engineering of their specific device. But ultimately, if your device isn't covered within the current reimbursement framework, you're unlikely to get reimbursed for it. Therefore, you've got no revenue. Therefore, you've got no business. So, from my perspective, from my background as a commercial director, I've really seen firsthand how it pays to be thinking about your revenue channels upfront as you start your QARA approval process. It just positions you very strongly in the market, and it is very helpful when your CEO or any CEO or commercial officer is going out looking to source investment. So in terms of what we're going to cover today, I'm sorry, I'm just making sure my just seems to be not going to the next slide.
Just click on the screen and then hit your forward key button. Sometimes it stalls. Yeah.
Oh, okay. So thank you. There we go. So really today is about medtech startups who may be planning a launch in the US, whether that's to hospitals, working with physicians and other payer stakeholders such as insurers. And what I'd like you to go away with is kind of an idea around the coding structures that you might need to look at to see where does your device fit and how much can you potentially charge and get paid for your device within the United States reimbursement framework. So it's going to really give you an understanding around what's a billable code pathway, how does that work, what are the coverage criteria, and then what's the payment mechanism that supports your economics or supports your business plan, because quite often people have an idea, okay, I want to charge X for a device, but you need to know, does that X that you're looking to charge fit within the reimbursement for a specific procedure or a specific action within the payer framework. So in terms of the agenda for today, I mean, I just referenced it, but why reimbursement is a first order go-to-market risk and opportunity. So why should you be including that at the front end of your planning as you look to build your business? Looking at the American in particular, the US coverage coding payment engine, obviously people tend to talk about the EU, but when you go into the EU, it's then very country specific. So today's really about the US because it takes us a month to do all the EU countries as well. It's also about looking at where does your device sit? Is it an inpatient device? Is it used in an inpatient setting? Is it used in an outpatient, in an ambulatory surgery center? Is it in a clinical office or a physician's office, or is it a home use device? Because all of that impacts your reimbursement pathway. And then I'm really sorry for everyone, but there is an awful lot of acronyms within the reimbursement system. So there'll be a lot covered today, but you will get this sent over to you. So I don't expect you to remember this as we go through, but these are a list of the codes. I'll explain them as we go. And once you get your head around them, they'll become second nature. Another thing that I really want to cover is kind of some startup failure modes, like what are the things that people do and how can you avoid those as you start to grow your business, and then look at a practical reimbursement work plan and a quick checklist that you might be able to take away and then apply in your business. So for startups, quite often you're looking to get into clinics, you might be looking to get into hospitals. And my background is specifically around actually surgical procedures. So I very much worked on the hospital side of things. And a lot of the time they might be looking at value analysis committees, and they want you to be able to show that your device can get paid. If you can show that your device will be covered, they are much more likely to adopt you more quickly, and it just gives you a very favorable door opener to be getting your devices approved in use in the hospitals. The payer evidence, so insurers or Medicare, for example, those needs differ very much from the FDA evidence that you might be required as a 510K or de novo pathway. You need to be really looking at the economic and utilization impact. So if you have, and I stated there, if you have better outcomes, how can you quantify that in terms of, length of stay, or, maybe it might be drugs used, it might be a quicker healing time. So you need to be really thinking about it from an economic benefit. And if the providers, if a hospital, for example, if they can't code it, if they can't justify it in their system or forecast a margin, because in the US, a lot of the time the hospitals, they're revenue generating, and they might have a code that covers a specific procedure. And if your device sits within that and is costing, 20% more than the predicate device, you're looking at eroding their margin. So there has to be some kind of, what's the additional benefit that you're going to be bringing to that hospital that means that they would want to adopt your device over somebody else's. And then reimbursement really determines your price corridor. So as you start to look at reimbursement, and we say reimbursement and we say the US, but you need to understand that there's huge variation from state to state. And even within the Medicare system, there can be 10 to 12% difference between regions on the reimbursement levels. So you need to factor that into your business planning. And then investors, and I've heard this a lot at recent events that I've attended, they're increasingly looking to assess the reimbursement risk early, particularly for hospital devices. The days of startups coming with a great new technology and doing a quick demonstration of efficacy and then being, bought out or managing an exit, that's not really happening anymore. People want to see it in use and being reimbursed, and that you've got a scalable business before they're looking, to buy in. So that's something to bear in mind as well as you start your reimbursement process. So the US reimbursement model is all around, is it medically necessary? So that, for the indication for use. So is it necessary? What happened in the procedure, what happened and how was it coded, and then how much and to whom, under which payment method does the device get reimbursed. So national coverage determination and local coverage determination policy is around the Medicare, the Center for Medicare Services. The coding, the diagnosis is it's the International Classification of Diseases. Now, I really see that as like your first starting point of, what's the disease state that your device is treating. So that's your CM code. If there's a procedure, that's your procedure code, your ICD-10 procedure coding system. And then what's your product identifiers? Now, the product identifiers, the UDIs, they tend to be used more in like over-the-counter products that might be reimbursed but are used in pharmacies, for example. That wouldn't necessarily relate to a device that's used in a hospital inpatient procedure. And then you go across and you look at DRG, which is diagnostic related group, APC, which is ambulatory payment classification, and then durable medical equipment, and you might be looking at prosthesis, orthotics, and all of those will then determine, how and when you get paid. So in terms of understanding that, you can't price a device or your new, unique, amazing bit of technology without knowing where it sits in the payment process and who's bearing the cost. Is it the hospital? Is it the physician? Is it the patient? Or is it the payer? So in terms of the site of care, the inpatient in a hospital, that's called Part A under the CMS Medicare, is paid under the IPPS, which is the Inpatient Prospective Payment Scheme, and they use medical severity diagnostic related groups in order to code. The hospital outpatient, which is Part B, is ambulatory surgical centres, and that's paid under the outpatient prospective payment system, and they use ambulatory payment codes, and then they look at coding bundles as well. And then in terms of, let's say a consultant or consultant services or physicians professional services, meeting to do a diagnostic assessment of a patient, they could be paid under the Medicare physician fee schedule and the CPT, which is current procedural terminology based billing. So the home is then your durable medical equipment, prosthetics, orthotics, supplies. So you can see how complex it's each, because each of these has its own bucket, its own procedures, its own process to go through. So it's an incredibly tricky scenario to navigate. And commercial payers, like in the US, obviously there's a huge business with that everyone knows around with the commercial insurers, with private health insurance that most people get through their employers. They usually mirror the Medicare, the Center for Medicare Services structures, but their contracted rates are usually significantly higher than Medicare. So in previous roles, I've always looked at, are we covered under the CMS Medicare, Medicaid system? If we are, that pretty much guarantees we're going to be paid under the payer, but it's still worthwhile to try and find out how the commercial payers reimburse to make sure that you are still covered. I wouldn't just take that as assume it. You need to just do a sanity check, and there are a lot of companies in the US that will provide those services and the data, even so granular down to a hospital and even to a surgeon setting, where you can look at the reimbursement rates. But I do think it's definitely worth looking at the states in which you wish to launch your device, and then looking at the reimbursement in those specific states, Medicare versus the national commercial insurers, and then looking at that regional payment, because the variation can be significant, and that of course will also impact your price point potentially. So there's not usually a one price point fits all situation where it's like a fast moving consumer good where this is the price and the price stays the same no matter where you launch. In the US, you have to allow for that fact that there are going to be variations, and so it's really useful to do a pricing elasticity model to look at your price point state by state, and then look at your launch plan and how does that impact your year 1, year 2, year 3 revenue forecast. So I've got a strategy question down here, which is, if you've got a bundled code, so if you're under a diagnostic related group and it's a code for a specific procedure, that code would cover, and for example, in a hospital setting, anesthesia, your single-use sterile equipment. It would include, maybe an implantable device. It would include the the surgeon's time, the scrub tech staff time, the anaesthetist time. It's quite a complex, depending on the nature of the surgery, range of items that specific bundle is going to cover. So is your device within that bundle? And then can you look at what proportion of that bundled payment could be allocated to your specific device? Or does your device have a separate payment? Is it a pass-through? Is it an add-on? Do you have a separate code specifically for your device? And do you have a contracted rate with a specific hospital where they pay you specifically for your device? So that's all things to consider as you're looking at your strategy for reimbursement. So in terms of the code stack, now this is a lot of information, and I kind of talked to you very briefly about this, but you're looking at almost like a pathway for the coding of your device. So you're starting off with your ICD-10 CM, your diagnosis codes. Then you're looking at, is it an inpatient? So then you want to look at, well, here's my ICD-10 CM code. What are the PCS codes that relate to that diagnostic procedure, that diagnosis? And then looking there, well, in which case, what are my CPT codes that relate to that procedural classification codes, and what are my MSDRG, my medical severity diagnostic related group codes, that under an inpatient prospective payment scheme. Sorry, it's such a mouthful. And then when you're looking at level 2 on your HCPCS, which is your harmonized common procedural coding system, your level 2 covers things like your products, supplies, durable medical equipment, drugs, outpatient, prospective payment system, the device, drug reporting, and then if your device is being used in ambulatory centres, then you'll be looking at APC, CAPC codes rather than your ICD-10 PCS, if that makes sense. I'm not going to go in. I've included them here. Things like the modifiers. Modifiers are kind of double-digit codes that would be used where you've got a procedure, you've got a code for your procedure, you've got your MSDRG, you've got your medical severity, diagnostic related group, and then something additional has asked to be happened, like for an example, a second opinion by a consultant. And that then has a modifier that's attached to reflect that that second opinion is included as part of that procedure, if that makes sense. Now, there are a whole list of those modifiers, and it is complicated, so I won't go into that here. And like I mentioned before, the device identifiers that would link claims to products, and that very much relates to, say, if a person goes to a pharmacist and they're getting a specific device that is an off-the-shelf device that is being reimbursed by their insurer, they need that device identifier to then make that claim. And the revenue codes, the UB-04, that's actually the form that's submitted by the facility cost centers. So it gives you, it's a whole claim form that gives you the billing lines and the information that you're providing to your payers, so to the hospitals who then use it to facilitate the claim around your CPT, your MSDRG, your ICD-10 PCS. That's all completed on that form, that providing everything is right, their claims are then not denied. And so that's a big issue in the United States, where if reporting is not done correctly, the claim's denied, the patient's left with a huge bill, the hospital's not paid, and that creates an issue. I noticed someone had their hand up there. Will I leave that to the questions at the end?
Yeah, if you could just pop your questions in the Q&A bubble. I did see as well, Stefan made a comment. This is why it's important to have one entity who control the pricing nationally, especially when you work with distributors.
Hard to do that, because who's the one? What does he mean by, who is the one entity? Like, I think it's important that you are managing your pricing, but where I've worked before, we had the pricing elasticity model. So what we were being reimbursed or charging actually in one state was almost double what we were charging in another state, because of their reimbursement pathway, because of the hospital contracted rate. You might come up against one example would be you're going in, you've got one device that could become part of a portfolio range of devices. The hospital has a contract with an existing large vendor that supplies the whole range of devices, and they only allow 20% off contract. So the maximum that you could do in that specific hospital would be 20%. And given of that 20%, there might be other smaller, suppliers like you who want to get a piece of that business. What proportion of that 20% and what value is that going to be to your to your company? So I think that's where it helps people, when you start the reimbursement process, to get very real about your sales forecasts, because you can't go in and just go, well, there's X number of these procedures in a year. In the first 5 years of doing business, we're going to go from 0 to 80%. Is an investor going to believe that story? Is that real? And if you think it is real, and you very strongly, you've got maybe you've got the support, maybe there's only 10 centers in the country that does the procedure that needs your device, and you've got all of those people on board, then great. But in my mind, until you've actually got a contract, a signed commercial contract, that's, it's not real, if that makes sense. So I think being, investors now in particular are looking for very real business plans and forecasts.
Thanks,
so in terms of the ICD-10, and I mentioned this, the International Classification of Diseases, the CM is the clinical reason for the encounter. The PCS is your hospital inpatient procedure coding, and that diagnosis plus the procedure coding then influences your diagnostic related group assignment, and then that therefore influences the coverage rules. So like I said, I think it's a really useful plan to start mapping the coding system early. There are lots of tools to help you with that. I think you can either work with independent consultants, or you can assign someone in your organization to do the legwork. It's a lot of legwork. I've done it from that kind of the ground up, and it's a huge amount of reading. You know, there are tens of thousands of codes. So, you know, having someone that can give you some advice, I think, is very useful there. And I did work with a consultant in the US on that. But if you look at your ICD-10 CM codes, if you can't answer that now, you know, at the beginning stage, then there's quite a bit of work to do. So I think it's useful to, you know, the sooner you start it, it just gives you a lot more leverage as you start to, you know, to build out your business, and it will showcase whether you actually have a potential business in the US or not. So in terms of the CPT, the common procedural terminology, this is the level 1 of the HCPCS. Like, they make it so complicated. So CPT is actually HCPCS level 1. So that will describe your kind of common medical services and procedure. And then you can look at category 3 CPT codes that provide temporary tracking for emerging technologies. Now, a lot of people ask, well, you know, oh, I need a new CPT code. You know, our technology is so new, it's novel. You know, we need to get a new national coverage determination. We want a new CPT code. I really, and a number of US consultants I've worked with, really kind of advise against that unless you absolutely have a breakthrough technology and device, because it's hugely complex. It's very time consuming. Looking at it'll add on at least a year to your go-to-market strategy. So you need to be, you know, pretty confident that that's going to have a, you know, a positive outcome. So it's not something that, you know, for the faint-hearted anyway. And physician payment under the Medicare flows through the PFS, the physician fee schedule, and they use what's called relative value units and conversion rates. And the relative value unit is all around how do they value the time of that physician or that service within the bundled reimbursement. So yeah, again, it's quite complicated, but that's something to bear in mind. And when you think about your device, if it's changing the physician workflow, if it's changing how a procedure is done, then you need to map it to the CPT codes and look at how your documentation supports changing that workflow, because that's significant. You know, that's where there tends to be a bit of, oh God, you know, if I've got to do something new, there's a bit of pushback on that, because people, you know, usually don't want to, unless there's a really, really strong driver from, you know, the outcome perspective for the patient. This is where you know, this is where this relates to the kind of the track below, that because there's a clinical action doesn't necessarily mean that there's a CPT code. So you need to do that mapping exercise, and a lot of device steps, you know, they're not separately billable. They come under that, you know, a bundled payment, and so you need to be really understanding how that payment works.
Alana, a quick question there. Are the
Yeah.
CPT payments, technical and professional in brackets, paid out of the DRG bundle payment, or a completely separate payment from the payer?
No, they're paid under the DRG, so they'd be paid under the DRG payment. They're not paid, so it would be one payment. It wouldn't be separated out, as far as I know.
Perfect. Thank you, my dear.
So in terms of where the product itself needs a code, and this is where we talked about the UDIs, this is an area, in all honesty, that I'm not that familiar with. You know, like I said, I very much worked on the hospital inpatient procedure coding area, but where the product itself needs the code under the level 2, it's looking at things like, you know, orthotics, prostheses, drugs, supplies. It could be, you know, various you know, equipment, tubing, for example, you know, for people who are intubated or who've got like COPD and they've got their mobile wheel, those types of things would be covered under the level 2 CPT codes. The HCPCS code here they still need the code, but if they need product level identification to adjudicate claims, that's where the UDI will come into play. And there's annual update cycles. So if you're launching a new device, it's always good to keep an eye on what codes are changing, because they change the codes on an annual basis. So it's always good to just keep an eye on that in case any are affecting your area of business, your device technology, your device application. So that's really, that's something that is good to look at. And in terms of, again, when you're looking at your device, is your product a separate device, or is it going to be included as part of a bundled payment? That's a kind of key question to be considering. And in terms of the inpatient, the hospital economics, the medical related diagnostic group they reflect average resources that are applied for that specific procedure. And I mentioned this earlier on, the device that you've got hits the hospital margin within that DRG. So if you're replacing an existing device that's priced at a certain amount and you're coming in 20% higher, that hits the hospital margin. And so there has to be a really strong story, a really strong value story for the hospital to make that decision to switch out from a pre-existing device that they may be using, or to add your device if your device is something new that's being added to facilitate a procedure. So it's really important to then look at that your coding specificity, I can't say that word, that places the cases into the right diagnostic related group, and then look at, could you be eligible for the new technology add-on payment? And that's something that comes around in a cycle. And I'd recommend, I haven't got a link here, but I'd recommend just looking that up and having a read about it. It's something that I've been looking at recently for a device where if you're adding more cost to a payment, that new technology add-on payment could cover that additional burden, and it would help the payer then say, oh, okay, then I'll accept, I'll take your device and we'll look at a contract for you. And commercial payers will use the DRG case rates, or they will look at negotiated case rate payments. But commercial payers are usually paying quite a significant amount more than Medicaid. But like I said, I always would look at to say, are we covered under Medicaid? And then it's more than likely, particularly in a hospital setting, you'll be either negotiating direct with the hospital, or if you're looking at a hospital group, you might be looking at a what's called a GPO, a group purchasing organization, and you can look at somewhere like Premier, Vizient, and they quite often will have a specific application for new device technologies, or smaller organizations that sit maybe outside what I know that someone like Northwell Health would call the mega vendors, like, which to me in my previous role were like Zimmer Biomet or Stryker, for example. So I would be looking at, if you've got 3 procedures, look at your DRG, look at the APR is called it, All Patient Refined Diagnostic Related Group. That's a whole beast in itself. But if you can look at that and look at your typical length of stay, your your OR time, how long is it going to shorten time in the OR and therefore reduce the cost? What's the device cost? What's the margin impact for the hospital? If you can create your value story with all of those included, it just helps you move the dial for approval. Now, the outpatient reimbursement, again, I haven't worked with many companies in this space, so this isn't something that I'm hugely involved with, but I thought it's good to cover here, in terms of those people who might have a device that's going to be used in, and I am working with a client at the moment where they're looking to launch into clinics rather than hospital inpatient settings. So, you want to look at, is there, ambulatory payment classifications, and then you can bundle your primary service plus any ancillary items into one payment. But there might be the ability for some drugs devices, via pass-through or other policies, to get a separate one-off, paid on their own. And again, for each of these, this is where I can't kind of model that for everyone that's on the call, but it's just for the people to bear that in mind. So if they sit in this space to do that analysis and to look at, can I be paid separately? Will I need to be part of a bundle? And then understanding how you're going to package and sell your device for APC or outpatient procedures. So I'm losing my voice a little bit. So the claim form, I talked about that a bit earlier on in terms of understanding the claim formats that the hospitals might use. This is essentially the codes that the National Uniform Billing Committee categorise and look at the harmonised common procedure coding system. And if they don't have the right codes, or if the codes are mismatched in any way, they can trigger those denials, which is what everyone wants to avoid, because you want to make sure that the procedure is paid, the patient's not left with an additional payment, the hospital's not left missing revenue, or having to resubmit. It just creates a huge amount of administrative burden. And a lot of the certainly from my experience, the hospitals are looking for anything that will help them reduce their time on administrative burden. So if you've got absolute clarity on your coding and how you'll be reimbursed, they're going to be absolutely delighted, because they then know that they're not going to have any issues in terms of claims being denied when your device is used. So you can actually go and look at some of the the big hospital suppliers. I mean, I know obviously I worked in orthopedics, so I'm talking about like Zimmer or Stryker, but you can look at maybe competitors in your space that are multinationals, and quite often they're actually publicly available, so you can go and look at their billing guide online, and you can just model that. Say, okay, well, I'm going to take that. I've only got one device and not 20, so it's going to be a bit simpler. But even if you just have a one pager, and quite often when you go through the value analysis committee route, they send out spreadsheets and you're asked to include your coding pathway within that spreadsheet anyway. So it's worthwhile knowing that, because you don't want to wait until you're having the conversation with the hospital to then start scrabbling around trying to find what codes you should be putting in, because it takes a long time. So I put that down there, a really, really practical deliverable. Just do a one pager if you can, on here's our device. Here's our ICD-10 CM, here's our PCS, here's our CPT, here's our MSDRG. If it's an APC, ambulatory payment, here's our ambulatory payment classification, and this is how it's reimbursed, and that will ultimately stand you in very good stead with your customers. So in terms of kind of common startup failures, I'm constant. I've got 10 minutes, so I'm conscious of time. Don't just assume that the existing code covers it. Validate with a coding expert. Do some real claim walkthroughs to see, are you actually covered under that CPT code? Don't just assume that you are. The coverage lag, that whole, there might be no policy, there might be restrictive criteria for your specific device. So, building evidence and engaging payers early so that you can align your indications and endpoints, it just, it makes sense. And, thinking all the time around your device cost erodes hospital margin inside bundles. So look at your model economics, pursue any add-ons. Is there a pass-through? What's your strategy, for any, new technology add-on payment? And then documentation doesn't support the medical necessity. So things like standardizing your operative notes. So I worked in, I worked in orthopedics. So the notes and that we very much looked at competitors' predicate devices, because our procedure was actually almost identical. So we were saying, it's almost identical, one small adjustment because we had a unique new way of inserting one of the devices, but it doesn't add any time to the surgery. That was the really key point. So mapping that, and then looking at the site of care mismatch, making sure that you're, is it inpatient or is it an outpatient, and design your clinical pathway and your billing pathway together to make sure that those match up. Because if you've got it's actually an inpatient procedure, but you've coded it as an outpatient, obviously That's not good. It's not going to get reimbursed. And I suppose the rule of thumb is if a hospital provider or a clinic or a coder can't code it in less than 60 seconds, then it's not a scalable commercial pathway. So just to bear that in mind. So if you are looking at reimbursement, I know not everyone on the call may be looking at reimbursement, but this is a really kind of like quick checklist of like, if you're looking at it now, in the next 3 months, here are some things that you could be looking at. So defining your indication, who's using it, where's using it, with what other alternatives are there currently available on the market. Map your coding stack for the top 3 use cases. What's the diagnosis, the procedure, the product, the setting, and the codes for each of those. Confirm the coverage. Is it covered under the national coverage determination, local coverage determination by CMS Medicare? Are there any gaps in your evidence to support that? Build your payment model. Looking at your DRG, your diagnostic related group, ambulatory payment, your physician fee schedule impact, and your provider margin analysis. So are you going to impact that margin for the hospital? And then look at producing your field tools or having some, value statements around your reimbursement pathway, even if you don't have, even if you can't get all of that together, and then set your coverage roadmap that then aligns to your FDA approval and commercial launch timing, because you'll need that all in place before ever your first case or your first commercial use. And while it's outside of all of this, I'd also bear in mind in the US that typically it's 90 to 120 days payment terms with hospitals, and and also with clinics, so you need to build that into your revenue planning as well. And interestingly, when we did our first case in the US, we actually got sent a check in the post. So by the time it was sent, regular snail mail, it was the 90 days plus then the amount of time it took for the post to get to us as well, which like another few weeks, and all of that counts against your cash flow. So you just need to bear that in mind. So the minimal team there, I know is it's not realistic, but I would recommend that you have one person in your organization that you make responsible for your reimbursement pathway. Like find someone, whether it's you might outsource it, you might say, okay, that's going to be the CFO's job. It's going to be, I wouldn't put this as the CEO's job. They've got enough issues raising money and being on the ground and being the front facing person for the company. Obviously they need to approve it, but I would definitely have somebody that is responsible for this, and I would integrate it with, if you're only at the early design phase, I would be integrating your commercial roadmap as part of your design validation phase 1, phase 2, phase 3 exits, so that when you have got a commercially viable manufactured device, you have also met and documented all of your commercial milestones in your QMS. That's something that I would recommend, because it just gives you such a solid basis then for your go-to-market and launch strategy. These are the key US code sets. I've talked to them. I won't go through all of these. You will be sent this, so you can look at them and then go and read up on them yourselves if you're interested. It's it's fairly complex, as I said, and I really hope I haven't absolutely bored you to tears. But I would be looking at using these codes in your investor decks, and it demonstrates that you've done your market due diligence. You're commercially savvy. You understand how the payment system works. You understand that this is informing your pricing strategy. It's informing your business decisions. It's informing your sales forecasts. And that, I think, will stand any startup in good stead as they go out and look at seed funding. Whether you're at you're at your Series A or whether you're at your Series B. And it just gives you that, I think it gives you a competitive edge over potentially other startups that may be operating in the same space as you. Who knows? So in terms of, this is the final slide, you'll be delighted to know. make reimbursement a design constraint. It shouldn't be thought of afterwards. It needs to be thought of right at the start, because this determines whether you actually have a business that you can scale and build and that you'll actually get paid for your device. You know, it shapes your indications for use, your evidence, your workflow, your value proposition, your pricing, and doing all of those actions around, you know, your site of care, your code stack, and your test coverage and your model provider makes your tools that you create then create billing and documentation that are easy for providers, and they will thank you for it, and ask early on, what's the claim look like and why will it pay? And so with that in mind, that's the end of and it really is, there's so much more to US reimbursement, but I can't cover it all in the time frame. So hopefully it's given you a kind of a flavor of the complexity of reimbursement in the US. And if you've got any questions that we don't get to answer today, you know, feel free to connect with me on LinkedIn, and I can share my contact details, and I'd be happy to answer them, you know, offline.
Thanks so much there, Alana. That's fantastic. I took away lots of stuff that I didn't know before myself. And you mentioned at one stage, you mentioned Medicare, and you mentioned about how much people pay for the device, and you said there's other kind of private commercial insurers. How can you engage with these people to actually understand how much they are willing to pay for devices? I mean, is that public knowledge? How do you get this pricing information from these people?
Well, one of the things that I do recommend to early stage medical device companies is that, you know, as they're going through their QARA pathway, there is actually an FDA early engagement with payers offering. So if you go onto the FDA website, you can find out about that. They have a list then of payers by state that you can select, you know, so you might say, well, I know that I can charge a reasonable price in, I don't know, Massachusetts, and I want to launch in Boston because it's, you know, easy to fly to or what have you. And so they can facilitate engagement with the payers and then look at your device specifically in, you know, in terms of the coding, coverage, and reimbursement model. There are ways to access data in the US. It's expensive. You know, there are companies where you can sign up to access the data yourself, which I wouldn't recommend because it's you know, it's terabytes of data. But there are various organizations that you can go through to actually get a reimbursement coverage guideline for even down to the granular level for a specific hospital and a specific, as I said, a specific clinician. So there are also people that you can work with in the US, and I actually do that with a contact that I have to look at specific codes and to look at the, like I said before, the all patient refined diagnostic related groups, because I'm currently looking at very complex surgical procedures. So to look at that, I want to do that with specific payers in specific states where a company I'm working with wants to launch. So those, but the early engagement with payers program with the FDA is certainly something I'd look at, because it's not a huge amount of money, and it just gives you that initial access if you want to get a feel for things.
A feel for how it could unfold. And we have a question here as well. Excellent intro, and thanks for delivering the overview. Quick question. How would you approach generating a code stack if it's more of a general use device? For instance, anesthetic monitor, where it is applicable across a huge number of primary diagnosis procedures?
That's a good question.
There's a lot of codes.
Yeah, a lot of codes. I would be looking to see, would that have a code of its own? But then you may need to know each of the codes for all of those procedures. That may well be something that you have to look at. I'm not sure, in all honesty, for that one.
Do you want to, I suppose, Alana, do you want to maybe think about that, and well, I can send out something a bit additional afterwards if you get a chance to kind of go in and think about it in a bit more detail.
Yeah, absolutely.
Thanks, Alana. And then Can you share your LinkedIn information? Great presentation, excellent expertise on the USA market. So that's for yourself, Lana. If you want to pop in your LinkedIn, anyone that actually joined be the LinkedIn event, I've got Alana tagged on all of them as well. If you want to connect with Alana, I'm sure she'd be more than happy to connect with you all. I think I had one more question for you there, Alana, before we wrap up. And it's about, I suppose, how do you integrate these activities with, your existing, processes and activities that are ongoing with getting your device to market? Like, at what points and whereabouts would these types of interactions happen?
I always recommend that the earlier the better, because it just means you're prepared. I had I'll give you an example. I was working on reimbursement. The reimbursement was all great. And then I had flagged to a company that we really needed to sort out device initial importer of record, our CFR 21 Part 11 compliance process. How were we going to physically get our devices from Ireland? They were manufactured elsewhere, but then in finished final form sent to Ireland, and we were then sending them on. How are we going to store them? How are we physically going to get them into the US? And it was suddenly a panic, because we had a case booked with a surgeon, with a KOL, and we needed to get our devices over there, but we didn't have our device initial importer. And we wanted to also, because it was a device where you needed to have multiple sizes, we had to ship a lot of them. So it ended up being quite a scrabble to then. It took us 4 months to negotiate our contract to then get the device initial importer and get our devices shipped. And it was a rush then, because we had a scheduled revision surgery that we needed. It was business critical to get our devices over. So I think the sooner that you have it done and you have it in alignment with your whole, design and development. So you're working, that commercial piece needs to be fully integrated with what's happening on with the design team, because you don't want to secure a hospital contract and then your design team saying, yeah, well, actually, we're going to change that PTFE to, we found this new, piece of material that we want to use. And so actually, it's going to take us another year to get a final device. And you've already negotiated a contract. So everything needs to be in alignment so that you have your commercial pathway with your finished, fully manufactured and designed product, with and you've got obviously your QARA clearance. What you don't want to do is have your QARA approval in place and then it take you another year to get to market, and you've lost a year. Your CEO is going nuts because you're running through your cash at a huge runway, a run rate, because you've got to pay your staff, your overheads, and you've still got to manufacture, and you've got to pay for storage, etc., etc. It's just a whole. So timing is so critical, particularly when you think about what's the shelf life of your device. If you've got a short shelf life, it's like, oh my God, you need to be able to turn that around quickly. You need to be getting usage happening, and then you need to be working out how your restock model is going to work. So it's just medical devices, and I know everyone on the call knows it's expensive to do. It takes an inordinate amount of time to get to market. So the better you plan, the earlier that you do these types of things, means you're shortening your window to market. And also, if you've got IP, and your IP is only valid for a certain amount of time before it becomes public IP, or patent runs out, or what have you, you want to be able to maximize your time, your usage in the market before you lose your patent, for example. So there are just there's so many moving parts, and that's why I'm glad I'm not a CEO.
Yeah, or made a project, a very busy project manager, and as you were saying, startups, SMEs, they're generally smaller in size and don't necessarily have someone for every job. So if you're working with quite a small team, how do you get around the amount of work that needs to be done here? I mean, what are the ways of getting this done?
There are. That's something that I do as kind of an independent consultant, working through Aztec Medical. So there are, Aztec is a prime, example of an organization in Ireland. I think it's very useful for, local companies to be able to work with someone who's on the ground here, who has established contacts in the US, who has actually done it with, with previous startups. I don't want to go into a hard, you know, I'm not here around a hard sales, you know, kind of scenario, but that's certainly one way of doing it. In terms of, you know, like I said, you know, allocating a person within the organization to be handling it within the project team. But, you know, there has to be, you can't do it as an afterthought. It has to be integrated at the front end. And that's something that I've been doing recently with a number of clients, is working with them on, you know, what are all your registrations that are needed? What are all your reimbursement considerations to take into account? What do you need to do around your pricing strategy? What do you physically need to do? And I know there's Stefan Tupan wrote there, Dawa Medical are a device initial importer. You know, who are you going to appoint? You know, what about your you know, ERP? Are you looking at your enterprise resource planning? How will that integrate into your current QMS? What's the QMS system you're using? How will you manage your stock on the ground in the US? How are you going to manage your sales? You know, is it going to be direct sales? Do you need to hire someone, you know, a sales director in the US? Really expensive, by the way. If you're going through a distributor model, distributors, great, they take a lot of managing. You know, you've got to have someone who's going to manage them to make sure, because they'll be managing a portfolio of devices again. So how are you making sure that they are, you know,
giving
selling
you the
your device?
attention that you
Yeah,
need?
yeah,
I think
exactly.
there's another question about, now we've got a couple more minutes left, so I think we have time. If a solution product isn't classified as a medical device, like some non-medical devices, CDS tools, how does that affect the reimbursement strategy? Can you see in the chat there?
What CD? Oh, clinical decision support. That would be, so that that is likely to come under. Again, I'd have to confirm that. It would be under the physician fee schedule, because it would be. Are they talking about, you know, some so like a service? So if it's a service that they're providing as part of the clinical process or the clinical procedure, then that would need to be, is likely to be budgeted within the physician fee schedule payment. So they'd need to be looking at that, and they would still need to know what the reimbursement codes were for the specific procedure that they're looking at, you know, the clinical decision support around. So they would be needing to look at the ICD-CM codes, and then how does that impact? So they would still need to look at the coding for that. It's the same as, for example, with an all patient refined diagnostic related group. That's a whole bundled payment for a really complex surgery, but you still need to understand what the CPT codes are bundled within that to then determine what the ultimate payment is. So you still need to understand your CPT, your MSDRG, because the other thing that impacts payment, and I didn't include that here, but again, I think it's something that you can look at as you go along, and it won't impact how it's likely not to impact the amount of reimbursement for a specific device within is a procedure. It's called MCCs, multiple comorbidities, or CC comorbidities, and those drive up because it'll mean that the length of time, if like, say for example, a patient's going in for I don't know, a coronary bypass, but they've got a history of pneumonia, they're a high risk, so that immediately they've got a pre-existing comorbidity, for example, or if they're diabetic, or if they're, you know, there's a whole other, that you can have thousands of comorbidities that could be assigned, but you have to be very careful around, or the hospital has to be very careful around assigning a comorbidity to reimburse at a really higher rate, because they can get fined if they're doing it and it's not actually correct. Then if they, you know, so they are tracked on how much they apply for the multiple comorbidities.
It's very complex, Lana, and we've one quick chat popped in there to say a quick word about de novo devices and solutions. So these would be a novel.
Yeah. Again, that's for novel new devices. I would still be looking to see, do they fit within an existing procedure code, or do they need a new code? And that means a new national coverage determination. There is a whole area on the CMS website around that if you want to go and have a look. But it's really going to, again, like I said, I think earlier on in the presentation, it will really depend on, does it really need a new code? And if at all possible, I kind of recommend that you don't go down that route. But sometimes people get really, oh no, but it's really new and it really needs a new code. It's like, no, actually, you know, it is still, even though it's a new device, it will still be covered under this procedure code. So I would look at that carefully.
Okay. Okay. So it's the same procedure, but a novel way of doing that same procedure, and you can use the same codes. Okay. And try and avoid new ones. So that's brilliant. That brings us up on the hour. I just want to take a moment to thank everybody for coming to the first webinar of 2026. Please join us and follow us to see new webinars coming up. We try to run one every couple of months or so. And I want to thank Alana for being here with us today and for sharing what is a wealth of experience, and for Aztec Medical for partnering with us again today. So it's been great to have you all here. I really enjoyed it.